What's up, everybody? Welcome to this week's episode of the Well Man's Podcast. My name is Brian Brosey. I'm joined by my friend and co-host Keoni Tita. And today we are joined by a very special guest. We are joined by Dr. Shirley Jones, MD. Dr. Jones earned her Bachelor of Science in Pre-Med Chemistry from Xavier University of Louisiana, and later a Bachelor of Science in Respiratory Therapy from Georgia State University. She attended Meharry Medical College and earned her MD. She completed an internship at Tulane in medicine and completed her family medicine residency in 2000 from the University of Alabama School of Medicine, War Eagle. And Dr. Jones, after 20 years of practicing medicine as a licensed and board certified physician for hospital systems, she decided to open a concierge and direct primary care medical practice. St. John's Direct Primary Care was created to provide high-quality, personalized medical care the old-fashioned way between the patient and the doctor. Dr. Jones believes that healthcare should be individualized, accessible, affordable, and not rushed. Dr. Jones believed that preventative healthcare should be personalized to promote balance of mind, body, and soul. St. John's Direct Primary Care offers a low-cost membership plan that is all-inclusive, no copays. Our membership program, or St. John's Direct Primary Care membership program, is like having a gym membership for healthcare. So all of that really resonates with Keoni and I know Dr. Jones, and thank you so much for joining us on this episode of the Well Man's Podcast.
Thank you for having me.
So you had an extensive career as well, kind of in the traditional healthcare setting. And as we mentioned in your bio, your practice now is a concierge practice. So when we say concierge and direct primary care, what does that mean to your patients, and kind of what does that mean to you in regards to your practice and how you practice?
What it means is that patients get individualized care to help them become healthier and to learn more about their conditions, and they get to be heard.
Yeah,
absolutely. Yeah, so you actually get to listen to patients instead of being in the conventional setting, right? Where it's like, I don't know, some of my colleagues said it's like 5 minutes per patient and you're on the clock. Like it's one after another.
Yes. So in direct primary care, concierge care, we don't take walk-ins. They're all scheduled visits. And we actually get to sit down with patients and listen to whatever they have, the complaints. We get to have time to discuss what else is going on, their diet, and all of this together helps us give them more personalized healthcare.
Yeah, and I guess you definitely get to know their families too. My grandfather was a primary care physician 30 years ago, and he said somewhere in the 1970s or 80s the system kind of changed to where he couldn't really spend the time that he wanted to. And he said one of the most important things one of the things he really loved about primary care is really getting to know the family. And he said it really added something to helping the whole family as a group, improve their health.
Yes, because we want to be considered as part of the family. So It helps with their health care, because if they have a high risk for something that goes on in the family, it helps you to diagnose and to help them to change their lifestyle or adjust their lifestyle to whatever diseases they may have.
Right. Yeah. And it's probably really rewarding for you too, because then you can really get to know like what is going on. It kind of, the thing I love about the concierge approach and, just this personalized, individualized medicine, it seems like it brings the art of medicine back into medicine itself. It's not so protocol based anymore. Okay.
That's exactly what it is. It's bringing old fashioned medicine back, because back in the olden days, the doctor visited the patients at home. They knew all the family, they knew where they stayed, they saw their surroundings, and it was a relationship between the patient and the physician. Today, medicine has been broken. Now we have so many middlemen in between the provider and the patient. A lot of times, if they don't mention what they want what problems they have, the minute they walk out of the room, they can't get back in touch with their doctor.
Right. Right. And that's a big deal, right? I mean, if you have somebody who's on, I can't tell you how many patients I've seen who have been on prescribed a number of medications, and they have no way or idea how to get back in touch with their prescribing doctor.
Right.
You know, which is astounding to me. You know, it's like, wow, then how can you help people if and when it's possible to reduce medications or come off of them completely, if and when it's possible? You know, it's just like, it's very hard. It's almost like once you're on a medication, there's this mindset with the patient, at least it seems to me, that once you're on a medication, you're on it for the rest of your life.
Right. And usually the way medicine is set up now with the large organizations and insurance companies, they push the physicians to see large panels of patients. So
Right.
You're right. It's like every 5 minutes, but it's really every 15 minutes because the other 10 minutes is spent in documentation.
Yeah.
So a lot of times patients see their doctors and they're looking off because they're on the computer. Wow. And so this is what prompted me I said, enough is enough. I did not go in to provide shoddy healthcare. And so I figure, if I do concierge and direct primary care, the patients directly talk to me. There are no middlemen. I give them my personal phone number. They have my text, my email, and we talk. And because sometimes you don't need a visit in the office. Sometimes it's just, Dr. Jones, I don't feel well. My stomach is hurting. This is what I ate. What do you think? And I text it right back. Or, if they're really sick, I try to keep them out of the emergency room in the urgent care because there's no relationship there. You're basically seeing a provider, which will not be the same provider if you go back again. And they basically have 10, 15 minutes with you and they diagnose you.
Right.
Most times they don't know about your medicines you're on, what you've gone through. And so I tell my patients to call me, text me, and there's a lot of things we can do that acutely I can do virtual visits or just pop them in the office, and take care of it. Even with vacations. So they won't have to go out of town. When they're out of town, they won't have to run to urgent care.
Right. Yeah, you're speaking our language quite a bit. We had our first podcast, I think it was our 4th episode, Keoni. This is like episode 100 and plus right now, Dr. Jones, or 180 plus. And we talked about developing a healthcare team. And just like you mentioned, too often in those emergency or kind of when we tend to go to the doctors now based off just the insurance models when something's wrong, not necessarily as someone who's part of our healthcare team. And all too often things get lost in translation and we're just missing that communication component. And I remember being in PT school and they told us if we just listen to the patient, 99% of the time they're going to tell us what's wrong. And our typical model today, and I see it even in physical therapy practice when I'm working for one of those big corporations, like you mentioned, I may have 20 patients that day and I've got 8 hours and they expect me to see them all and see them in a certain level of productivity. And then in my own practice, my goal is to see 20 patients a week. So you can just imagine how much better the time gets distributed amongst patients and you actually get to communicate and know them. And I know that was something you mentioned to me, kind of about how the annual physical works. And can you take us through your process of if someone you're their direct primary care, can you talk to us about the annual physical process and kind of what that entails for you?
So the annual physical process, so I have a membership plan. The membership plan includes the annual physical, which is roughly about 2 to 4 hours. And that depends because it's personalized, it's individualized to the person. So if you have a lot of, issues or complaints or questions, we take the time to go through that. With that annual physical, we discuss each area that is in wellness, which is your mind, your body, and your soul. So not only do we do the physical part, we talk about, what are you eating? Where do you want to be in as far as your health is concerned or your exercise is concerned? Or are you happy with where you are? Are you happy with your weight? Are you happy? Just happy? Do you not like your job? Are you being abused? You know, so many things we have to talk about to get to know the person and create a relationship where I can help them become better people.
Yeah.
Which is healing in itself, just creating that relationship.
Right, just creating the relationship.
How easy was it for you to break away from the conventional model, right? Because I'm assuming once you got out of medical school, you did your residency and everything. I mean, you're pretty much it at least may not get your first pick, but you're pretty much guaranteed a job somewhere as a medical doctor, right? And I notice a lot of my MD friends would at least come follow me around and be like, well, how are you running a cash-based practice on your own and you're out of the system? And I was kind of, based on what I do, it was forced on me. I had to do that. Like I didn't have the opportunity that you or Brian had, where, you know, you had a job in waiting, so to speak. And it made it harder for people like you guys to kind of break away from that system, right? Because now you got, like, how do you deal with insurance? Like, how do you deal with your overhead? How do you deal with a practice like that? I mean, it seems like there's a lot of bumps in the road to develop a practice like this.
So the biggest thing is the paradigm shift with the people, because the United States makes us think that we need insurance.
Yeah.
And that you pay this large premium. If you have one illness, you know, you're probably paying $800 or $1,000 a month for insurance if you're not working for someone.
Right.
Right. If you're just paying it out of your pocket. Then if the family is, you know, it's outrageous. So people are in the mindset that they need insurance, and that's the only way to get health care. That you have to go, I have to go wait in a doctor's office. I have to be assigned. When you know, this is a paradigm shift, because we're trying to put it out that all you need is a doctor and yourself to get your health care.
Right.
Or a provider and yourself to get your health care. You don't necessarily need insurance for outpatient health care. Now, I do suggest to still carry like a high deductible plan.
Yeah.
Because that'll help if there are any emergencies where you do have to go to be admitted to the hospital. It'll help you pay that bill.
Which you can do fine. You can definitely admit somebody and send them where they need to go.
Yes.
Pretty easily.
Right. I coordinate all of that. I have my specialists I deal with all the time, because, you know, working for 20 plus years, you know, I've had relationships with a lot of specialists. So, you know, if my patients need to be seen and it's something that I can't cure, you know, I just pick up the phone and call the gastroenterologist. Hey, I got this guy I want you to see. And with our relationship that we have, they see him the next day or sometimes the same day. Yeah. Where that's the big difference with going to large corporations with insurance. You have to put in a referral, which then has to be sent over to an office by clerks that they have to approve. Then they're going to call back and say, you need to submit office notes. So, you know, the whole process, the way medicine is now, it takes about a week to get referred.
Yeah. Yeah. And it seems like you cut your time down, right? For like admin stuff, paperwork, doing what you're doing now compared to what you could have been doing in a big clinic setting.
Yes.
Okay.
So in a big clinic setting, just to tell you, with us directly dealing with patients and the physician, I'm purely paperless. And so they have a portal they can go on, they can schedule their own appointments. They have direct access to me. If they ever need, you know, med refills, is just a click of a button. It electronically goes to, you know, the pharmacies, and, you know, it's a pickup of the phone of, you know, if they need to see a specialist, if they are at that point. If they're sick enough that I deem that they need to be admitted to the hospital, then I pick up the phone and call the hospitalist, and I direct admit my patients. So I definitely try to keep them out of the, you know, the ER, the urgent cares. And what happens with that, it reduces the paperwork. Right. Because then all I do is, you know, everything is pretty much, I decide, is covered under the membership. because I take out lumps, bumps, and not accepting insurance. I don't have to jump through all the hoops
right.
that insurance make us do as physicians to get paid. So the purpose of seeing so many patients is because insurance don't pay, they don't reimburse physicians well.
Right.
So physicians have to increase their, the load of patients in their panels. So that's why the average physician has about a panel of, 30,000, 15,000, and they want you to see about 20, 30 a day.
Right.
But I reduced mine down to a total of 400 memberships.
Yeah.
And that allowed me to spend 2 hours and, 4 hours with my patients.
Well, let me ask you this. So one of the issues I have is, the insurance, I dealt with insurance and it just doesn't reimburse anything. And in fact, in my small clinic, some of it, I just can't, it's like years ago, I'm not going to get reimbursed. It's like work's lost. It gets sucked up in a black hole somewhere. And I just don't have the time to follow through on all that stuff. But if you're concierge program and people are paying a membership, it seems like, and this is the problem that I see, it seems like you are giving healthcare to people that, are upper middle class and upper middle class type people. And that's what's happening to me. Like, and I know the medicine I practice is going to be better served in the poorer communities. Because I just deal with lifestyle medicine pretty much,
Great.
So how do you rectify that in your practice?
So
and is it even true what I'm saying for you?
Well, sometimes, because that goes back to what I was saying about there has to be a paradigm shift.
Yeah.
Because these same people, a lot of people think that being concierge, because the word concierge lends itself to think middle, upper class,
right.
know. And so they can understand that a lot of the direct primary care, we have different levels of membership. So some of them are as cheap as $97 a month.
Right.
And so if they go with a high deductible plan, it's a lower insurance cost. And then direct primary care portion of it, they actually can file that back to their insurance themselves. I don't file it, but they can.
Yeah, I do the same. Yeah.
Or with the card.
Right.
The HSA card, they can actually use that card because the government asked it.
Right.
Do that. But one other thing that allows me, by not taking insurance, it allows me to do pro bono work. Okay. Because there are people that I feel that I need to help. Like I have a 90-year-old that was my patient. She's been my patient for years, that she's on Medicare, and I withdrew from Medicare. I don't, because Medicare is, that's a whole nother issue.
Yeah. I dealt with the VA too. It's a whole nother issue.
It's a whole nother, and they don't allow you to discount other people if you're taking their insurance, And so she really wanted to stay with me because I'm part of her family.
Right.
So I do, she's of course I don't tell her she's indigent,
Right.
Yeah, but I don't charge her. So I do leave a certain percentage of my practice for helping people that need help that may not be able to pay me.
Yeah, that's great. I kind of do the same, have hours set aside for people that may, be struggling. But even at night, let's say at your low tier concierge program, $97 a month, right? A lot of people, especially when you're primed and kind of brainwashed by the insurance system, will think, well, 97 bit. I mean, I don't go to the doctor unless I'm broken, and that's a shame, because that's how a lot of people in this country use it. And it's kind of like it's an education, right? It's like you have to, because you're there to keep them away from the doctor, so to speak, right? Or the specialists.
Exactly.
And so there's a lot of education, at least on my part, that goes into that. And even taking it a step further for me is, I love that you used the word cure, because I know a lot of doctors and scientists would roll their eyes at that, but I actually use the word a lot because, we know that type 2 diabetes in at least the early stage can be cured,
Exactly.
And we know that, sleep issues can be kind of mitigated with all kinds of lifestyle changes and things. So I love that you do that. And I think that, when I say that to patients and let them know, this is the reality of the situation, especially when we're talking about diabetes, it's like, you can reverse this and actually cure this, and you can reduce your medications at the very least if you stay with this concierge program and just follow me and touch base with me, so you don't get lost in the system and we lose touch. It's
Right.
that building the relationships, which can really help. So it's just an education thing that's crazy that you have to, kind of drill into people's heads. Like, this is going to be better for you to do.
Exactly. And we're fighting against the media and big pharma and, everything that's out there that says, commercials come on so often about these drugs.
Right.
And, are what we eat.
Mm-hmm.
We are
no doubt.
how we treat our bodies.
Yeah.
And so I love the education part, because I'm able to educate my patients in concierge practice, because, I'm not trying to see so many patients that I have time to talk to them.
Right. Yeah.
Which is where the real change is made, with being able to educate a patient. Yeah.
Exactly.
And it takes that shift of just kind of realizing it financially as well, I'd say, Keoni, because like I was talking about before, I had to go to the urgent care this weekend. I pay $150 a month for insurance. The urgent care visit cost me $80, and I left real unhappy and didn't have a great experience with the PA I saw for 45 seconds. And now I just sit here and await whatever the bill is that is eventually going to come in a month or a month and a half, and who knows how much it is and whatnot, versus you could actually plan out a lot more of your healthcare expenses in one of these types of models. You're going to spend that $97 a month. And, so times 12, that's going to be your healthcare expense plus, a high deductible plan, kind of like Dr. Jones is mentioning.
Mm-hmm. Yeah, I think at the end, it ends up being a lot cheaper, and the education piece you get kind of gets passed down to your family members and so on and so on, especially when we're talking about lifestyle medicine. It just feels like, at least with my colleagues, the art of medicine is lost. It's very protocol based. You have high blood pressure, then you give these meds. You have, a headache, you give Imitrex. It's like, without even thinking about, well, why do you have the headache? It's the maybe don't be drinking 3 Diet Pepsis a day. That may
or those Red Bulls.
No, exactly. Yeah. Or the Red Bulls. Yeah. And how does that affect sleep? So it's like, I don't know. It seems like the common sense has been taken out of medicine, and then with programs like this, you're putting it back into medicine, Yeah.
But, we have to all get together and create that paradigm shift.
Right.
Because, it's everybody's brainwashed of, this is how I'm supposed to act. I'm supposed to go to a doctor's office and wait an hour to 2 hours to have an appointment.
Right.
It's concierge medicine. I only see who I've, scheduled, or if they've scheduled. And so there is no wait. You come in and, I'm here exactly for my patient.
Right.
You mean I don't have to wait in the waiting room for 90 minutes to see you? That's not a prerequisite.
No, that is not a prerequisite.
And then the other thing is, you open yourself up to people all over the country, right? I mean, that can call you. I mean, that's why one of the reasons why we're doing this podcast is to, so people will know about you and can, see you and see what you do.
Yes.
Are there any problems with that, though, at least with the way you're practicing medicine? If somebody's in another state or another country, do you run into bumps in the road with that at all?
Well, the only problem would be, they won't be able to come in the office.
Right.
But, we could do it telemedicine.
Yeah.
Okay. And then, going to medical school and residency at all these different places, I have quite an extensive array of specialists that were my classmates. So in a lot of cities, I have people that if I need someone to take an eye for me, I can, send them there, just pick up the phone and call them. Yeah.
So there's no issues. There's really no issues with like, out of state referrals or anything like that to other people, right?
No.
Okay. And do you actually see international patients too? I mean, I guess
I haven't started yet. No.
Okay, but it wouldn't be a problem, right? Especially if you're acting as a consultant.
Right. Long as I'm acting as a consultant. Right.
Okay. Yeah, that's good to know for a lot of our patients. I get the sense that you were, the reason why you did this concierge program, you got a little bit jaded by the way medicine is practiced. Correct? I mean, it seems to me that trained as a primary care physician, a strictly primary care physician, you're an expert at diagnosing, the common stuff, but you're also, how do I say, you are trained in a very certain way that takes away the art of medicine, but you're not really, you didn't really get the education of what I would say is lifestyle medicine or functional medicine as more, I hate this term, integrative physicians. I like saying comprehensive, but how did you supplement your education with the whole lifestyle stuff? Because when I think of a stereotypical primary care physician, I think of, oh, you go and see the doctor. Okay. Your cholesterol is high. Here's a stat. Oh, you got a little cut. All right, here's some stitches, and go on your way. How did you supplement your education? Was it through the residency or?
Well, I was in residency a long time ago, so no, it wasn't even, they never even mentioned lifestyle.
Okay.
But what happened was I became a gestational diabetic when I had my daughter. The diabetes didn't go away, but it stayed. And after, and I was going to beat that. I said that I'm not going to be a diabetic for the rest of my life, because I left the hospital on all types of insulin, like two injections 3 times a day. So after that, and medicine. So after that, I started doing research and talking to people, because I've always been more of, there has to be a better way than putting people on so medication, because you got to find out why.
Right.
Why all of a sudden, I turned from this person who took nothing to, all this blood pressure medication and diabetes medication after this pregnancy.
Right.
And so that's how I got into doing the research and finding out that there were people that were being cured and all of that. And then I sat back and I read more and more and studied and started doing research among my patients of doing, and then I realized, oh, wow, there's a whole lifestyle medicine.
Yeah. So a lot of it was on your own, like you came upon.
Right.
Yeah. Yeah.
And so I also, being a physician and being a scientist, I, come up with my hypotheses and I, do my trials, and I've done my trials. And then I personally did a trial. So I turned into a vegetarian, and I changed what I ate. I started exercising, doing everything. I lost 60 pounds. Wow. And I'm 60 years old. And
that's crazy. You're 60 years old. You look young. 60 years old. Yeah. So you're proof.
Nothing but water. So I've proved.
Yeah, you're proof of it.
I'm proof of it. And so I let my patients know that. I show them all pictures, and and especially with people who have a problem with weight, because I have a program that teaches them it's weight release and not weight loss. Yeah.
Right.
Because you find things you lose.
Yeah.
So,
and that's so true. That's so true with weight loss, right? I mean, you get this rebound weight gain a lot of times.
Rebound weight gain. And all of these for money things that come out, or do this diet, do that diet, And that's why education is so important from us, you know.
Mm-hmm. Yeah. Well, and you know, it's fascinating talking about diabetes.
Mm-hmm.
It's when you think about how we actually treat diabetes in this country, it's like you're doing exactly the wrong thing. I mean, I understand insulin is needed at a certain point and you absolutely have to do that, but insulin basically creates that cycle of weight gain, elevated blood sugar, so on and so on, and then you start amputating limbs, so on and so on, you know. Yeah, and then the information that some of my patients come in with diabetes where their doctor or whoever will say, well, you know, to keep your blood sugar levels stable, you need to eat 3 meals a day plus snacks. And then you're like, well, that doesn't make sense either, because now your blood sugar never gets a chance to go down and have a rest. And that's why I'm fascinated by a lot of the intermittent fasting research out there, where you just put more space between your meals than you normally would, and you can acclimate people slowly into that. Mm-hmm. I mean, right there, you know, it's like, how are you going to lower blood sugar levels? You know, at least one way to do it is trying to put space between your meals. It comes down so you can start, you know, blood sugar falls, insulin level, you become more insulin sensitive, you start burning fat a little bit better, you start sleeping better, and then decrease your risk of cardiovascular cancer and so on. And it's like just that little bit of information goes a long, long way. Like there's so much misinformation out there about, you know, and with, you know, you brought up, I want to speak to this because I agree with you. I think people I think, you know, one thing we know, I mean, I know nutrition, you know, research and you eat this way or that way. It's almost like religion, right? Everybody has their special way. But one thing we know is if you eat a plant-based diet, the research is pretty much going to tell you that that's what's going to really help you, you know, to get healthier.
Right.
You know? And then we also know that eating less without stressing the body, so to speak, is also going to help you.
Exactly.
Get better. And it's just crazy to me that this information is just not talked about at the primary care level in the conventional setting. You know, it's just common sense stuff.
And if you get a chance, I want you to go to the ADA website.
Yeah.
Check out the diet.
Yeah.
The diabetic diet.
Oh yeah.
Full of milk, full of meats.
Right. Yeah, it is. It's unfortunate. It's really unfortunate because it's like you really have to change your approach and do a lot of education yourself to you know to get out of that. You know, and we know how that stuff is. A lot of that stuff comes into place through lobbying efforts, not necessarily science and stuff like that.
Political, all of it's political.
Yeah. And hence our system too. What are some, so when you do your concierge program, you have somebody come in, I know you probably do a standard level of blood work, right? The regular chemistry panel. Outside of that regular chemistry panel, if somebody's coming in, needs blood work done, are there any other tests that you really think are important to help people maintain their health besides like a standard chemistry panel?
Oh yes, it's a lot of tests I do because, you know, since we are chemical organisms, you know, all the body processes have to have the right substrates for chemical processes. So, you know, and that's where history is very important because it helps lead me to an end. So it's not a cookie cutter lab.
Right.
What I'm trying to say. But that's why the visit is 4 hours. Because first, before I order labs, I talk to the patient, I find out how they live, whether they're a couch potato, why they're couch potatoes, are they happy? And from that, I decide what labs I need.
Okay.
Then for that person, you know, a male who's 60 years old, who's a couch potato is not going to be the same cursory labs for, you know, a 24-year-old that has, you know, a thyroid problem.
Right.
And so, but I check minerals, I check a lot of the other, pretty much like the functional medicine.
Yeah. So you do,
yes.
you do a lot of functional medicine tests. Some of the conventional tests that I've started running across the board on some of my patients is I always run a vitamin D now, because most people seem to be low. I've seen very few people, unless they're just supplementing like crazy with high vitamin D levels. And the one test that I run, speaking of diabetes, and I'm starting to run just on everybody, is the hemoglobin A1c. And I run that not to try to diagnose diabetes. Most of my patients are pretty healthy. To just track that and see that, where you're headed, and then try to optimize it to, the number I really like, based on what I've read, is like 5 or low without low blood sugar symptoms. That's where you should be. But it's a marker of aging, right? Yeah, it's one marker of aging. So if you can optimize that, you've actually slowed down the aging process. And if you slow down the aging process, guess what? You slow down all the disease processes in a sense. Yeah.
Exactly.
And so what gets me is, so it's, I don't know how you feel about this, but it's almost to the point, this is a pet peeve of mine in medicine. It's like, we know, and I'm getting on my soapbox now, but I think you're with me there. But we know that, heart disease, cancer, all the chronic diseases are pretty much diseases of aging. And the doctors that kind of are focused on slowing down the aging process are people who individualize medicine. That's what we're doing. Like, we're trying to slow down the aging process so you can live a greater health span without, getting one ailment after another, and then getting one medicine after another to manage the symptoms, which, and as well as I do, like, once somebody's on more than 4 or 5 medicines, now the problem becomes part of the medicine. It's the medicine that's the problem.
Right. Exactly.
And for me, that jazzes my patients up. It's just like, let's do what we can with common sense stuff without taking a ton of pills and potions or whatever to slow down the aging process.
Yes. I wholeheartedly agree.
And it's funny because in I don't know, did you ever get this in, medical school or in your education? It sounds like you haven't, but aging is one of those things now that is like on the cusp of we're not going to deem it as a natural process. Like, we're going to deem it as a disease, so to speak, so that money is funneled into slowing down the aging process now, so we can put more research into that.
Right.
I think that there's just fascinating research on that. And I just think, like, the pioneers of slowing down aging are people like you, with the way you practice in medicine.
Well, thank you.
Well, it's proof. It's proof the way you look.
Yes, but the hard part about it all is they meaning the pharmaceutical, big pharma.
Right.
That's how many Alzheimer's medicines are there? How many diabetes? They're making this it's a $1 billion industry.
Mm-hmm. Yeah.
And so, it's quite a fight.
Yeah.
They're going to try to discredit us.
Yeah. Oh, of course.
Yeah.
And that's the other thing. I wonder, have you been ostracized for what you're doing from colleagues or anybody from, going out on your own and doing this at all?
No.
Like, I'm just, okay,
not
good.
So far, no. Everybody seems to be happy, and everybody was like, "Oh wow, I've never heard of that."
Yeah, right.
I'm like, how
right.
are you?
Yeah.
Because
I just
roll back 20 years, there were a lot of providers in private practice that never accepted insurance.
Mm-hmm.
If you roll back 20, like in the 70s, and even before the 70s, that people hung their shingles out, and there was, insurance.
Right.
They just went and paid with a chicken or pay,
Yeah. But on the same token, like, I just know, like, the way my grandfather practiced, he did practice like that. He was like the town doctor up in Long Island, New York, and he would go visit patients and everything. And that just fascinated me. I was like, I want to be a physician and stuff like that. But the thing is he never got completely outside the box of practicing in a conventional way. You see what I'm saying? Like it was like, I just don't know if the information was there or if there was, but he did everything. Like he delivered babies. I mean, he was like the town doctor. And that's the other thing. Like now it's so specialized. People do certain things, but now I think, as a medical doctor coming out of medical school, it's kind of like you have to do your own further education to really help people get well instead of just managing symptoms.
Right. Well, I think some of the newer residency programs in some of the medical schools are starting to integrate.
That's great.
They're starting to, because now you have enough people where I guess physicians are getting fed up, with being, like puppeted by the organizations.
And getting burnt out and just getting burnt out.
Right. Getting burnt out.
Yeah. Yeah. It's kind of crazy. I just know there's a lot of fear around physicians getting away from the big ivory tower, so to speak, and going out on their own. They feel like, it's secure over there, even though they're not completely happy.
Right. But it's kind of like, it's easy because everything is done for you. Mm-hmm. So if you go work for someone and they telling you what to do and you're seeing all these patients, and then the other thing we didn't talk about is when you're in these big situations where you have to see so many patients, usually those doctors go home and you're charting for another 4 hours.
Oh yeah. Yep.
So your 40-hour work week turns into 80 plus.
Right.
And you're getting call.
Right. Yeah. So then you lose family time. You don't get to
right.
You don't get a reprieve from the work life that you have.
Right.
And then so it's like, after a while, it's just awful. It's like beating a dead horse, right? You just you're going to get burnt out on that.
You're going to get burnt out. And it's sad because nowadays you hear more about provider and physician burnout than you ever have heard.
Right.
Right.
Yeah. And for some of my colleagues, especially in primary care, they just said the compensation is not even worth it anymore. They're trying to, go into new careers or whatever, or try to open up practices like you have.
Right.
Was it a smooth ride for you initially getting into?
Yeah, I just did.
Really? So you just decided? That's really cool. So there wasn't a big bump in the road for you then. You just
transit. No, I was like, I've had enough. To the point where what really got me was when there was a test I needed to order for a patient, and she needed this particular medication too. And her insurance company kept refusing. And so I would have my staff to go call, I could talk to the doctor at the insurance company so he can try to, give them all their information. And then he was like, well, I think you should have tried this first. And I was like, no, I can't try that because, she has metal in her hip or whatever.
Right.
And then that was what was required for him to approve the medicine, which I really didn't need the test. It was for them.
Right.
I was like, this is ludicrous.
Yeah.
I have the experience. I'm sitting here treating this lady. I've been treating her for years. I know what's going on, and I can't even write the correct medicine she needs.
Yeah.
That's crazy.
It's crazy. I was like, I've had enough. I can't do it anymore.
Right. So how long? So how long have you been doing what you're doing now? Then
it's been a little over a year.
Okay. So you're happy where your trajectory is, right? With what?
Oh, yes, I'm a lot more. I get time to spend with family. And it's amazing, even though I'm giving patients my cell number and they really respect my time because they feel like I'm there for them.
Right.
So they're not constantly bugging me and,
Yeah, that's my experience too with my patients. It's like, I don't have a problem, especially if they need it.
Yeah.
Give them my number or whatever if they need to talk to me.
Right.
Yeah. What are the main conditions that you see as a primary care? I mean, do you mostly see diabetes? Is it everything? Like,
yeah. It's pretty much everything. I see diabetes, thyroid, hypogonadism, high blood pressure, cholesterol, heart disease. I mean, the whole gamut of it.
Right. Yeah. Yeah, I would assume so. As a primary care physician, you probably see you're the gateway, kind of the gateway keeper.
Yes, and because I did an internship in medicine, so I'm probably a lot more experienced with specialty work than most family practice doctors.
Okay.
I've worked ER, and I've put lines in. I worked ICU,
Mm-hmm.
I've done it all because I did a lot of rural medicine at the beginning.
Oh, okay.
So we had to do everything. So I'm pretty comfortable where, most times, I don't have to refer out much, but I do, or it'll be, like my referral source, they were like, oh, Shirley, that, do this time, and then I'll be like, okay.
Right.
But once I've become more educated in the functional medicine side of things, I'm starting to see, different changes.
Right.
And that's what I like about being in concierge and direct primary care is the autonomy.
Yeah.
And the time that I have time to sit back and figure things out. And that's what we do best. That's who we are.
Right. Yeah, you can think things through.
I can think things through and figure it out
based on. It speaks to what you guys were talking about earlier, where the system almost makes you like a technician. You run through these steps and you hope it works out. And when it doesn't work out, you move to the next one. And you just kind of continually do that. And it's like you said, it's almost laid out for you, which is unfortunate, taking the art out of the whole situation.
Right.
Yeah.
In your experience, Dr. Jones, who's the patient? Who's typically coming to you? How are they finding you? And not necessarily how, on Google or whatnot, but like what is bringing a person to make that paradigm shift on their own?
They're disillusioned and very unsatisfied with medicine. They feel like they're not being heard. They feel like, I can't get in touch with my doctor, or they never see a doctor. They see, a nurse practitioner, because as you know, the way medicine is going, they are replacing a lot of doctors with nurse practitioners. And the nurse practitioners are able to get a doctorate degree, so they're being called doctor, but a lot of patients don't realize it's a nurse practitioner.
Right.
And so a lot of them find that out, and they're very upset.
Yeah.
And they just feel like they are just a number.
Right.
They're like, I meant to tell her this and she didn't listen, or I couldn't get in with this person, Yeah.
Well, it brings me back to, sorry, go ahead.
Those are most of the complaints, the people that tend to come over and are willing to try.
Yeah. Yeah. Well, it brings me back to kind of you mentioning like an ER visit or talking with the hospitalist and really driving kind of that healthcare team, which sounds, that sounds worth it in its own, to have someone in your corner as you're going through the ER. Maybe you're not able to kind of advocate for yourself, but can you just touch on that a little bit more as far as, like my example this weekend, sliced my thumb, had to go to the urgent care to get stitches. In that situation, if I'm a member with you, am I able to text you, show you a picture of my thumb? You tell me, yeah, that probably needs stitches. Do I come into you? Can you coordinate with the ER? Obviously stitches, probably a low level example, but something more severe even. How does that work with kind of the ER, and then as well as within your membership program and you communicating with that staff?
So at St. John's Direct Primary Care, I think I may have told you all before, I've worked urgent care and ER. because I have some surgical training too. And so that's how I keep up my surgical training. So usually the patient will call me, Dr. Jones, I cut my thumb, send me a picture. And if I can't see the picture well, I was like, let's do, FaceTime. Well, not FaceTime. We do the HIPAA compliant version.
Yeah.
And look at it. And then if it's something I feel like needs that I could do, I'll meet them in the office. If not, if I think it's a little bit more involved, I'll call maybe a hand surgeon and say, hey, I got this, shoot the picture over to them, and they'll tell me, I can just do it in the office, or I'll meet you in the office, or, which way. Or if not, there's like, go to the ER and meet them in the ER, or I'll call the ER and tell them. And the thing is, the ER loves it, because when they have a physician that's calling them, telling them about the patient, then I actually tell them what to do and what I expect. So they don't have to run a gamut of, because they know what I'm looking for and what I think it is. And so they pretty much carry out what it is. And then I communicate with them like, okay, and they'll say, well, I sewed it up and there were no nerve involvement or tendon, so they don't need to go to surgery. Or if they do need to go to surgery, who would you like me to use? And I'll tell them, oh, call such and such and such, and then I'll call the doctor and let them know. And so it's pretty much, a concierge treatment of you all the way through the system. Because if anybody was ever on the other side of the system, you see it's chaotic.
Right.
Yeah.
Stay in the room bleeding a long time because they're just overwhelmed.
Right.
And so a lot of the ER doctors and the providers are very happy when concierge doctors call them, because they know exactly what they need to do. The other doctor is you're pretty much handling it.
Yeah. That sounds so valuable.
And the patient. Oh, absolutely. The patient has somebody that has their back the whole way through.
Exactly.
Yeah.
Example I will give you, I had a patient who I had been trying to get
There he is. He's back. Oh, we got you back. All right, cool.
So I know it cut out because I'm doing doing the recording. Dr. Jones, you were just about to get into kind of the example.
Okay. The example is having a patient who caught COVID, and with the apps, we use the apps to monitor his pulse ox at home, so he could at least stay at home until things got worse. So with that, I was able to get all of his information. And as he became more short of breath and his pulse ox start going down, I was able to coordinate with the ER to tell them I'm sending him in. He has COVID. He's not able to keep his pulse ox up, and he's getting respiratory distress. They directly admitted to the ICU, and I was in contact, and I coordinated with the ICU doctor, his care.
Yeah, that's incredible.
And what I think it's just going to get better and better, right? Where you're going to be able to monitor somebody from a distance, all their vitals and everything. I have some of those glucometers talking about diabetes, and just so you can just see what's going on and what they're doing when they're eating, and so it's pretty cool. It really adds a neat component to medicine to help move people more towards health.
And see, in concierge care, we could do that. But, when insurances are involved, it has to be, whether it's approved or, will we pay
medically
for it,
necessary, skilled, all that.
Right. So.
Anything else, Keoni? It's going to come to mind.
Dr. Jones, I love what you do. I mean, I want people to know who you are. I want, you know, I'm thrilled that I'm talking to you and that Brian introduced me to you, because I would love to refer patients, at least if they're in your neck of the woods, to you, but also virtually, you know, just so they feel like they have, you know, a primary care doc on hand that's, you know, has their back.
That has their back. Yes.
Yeah.
Dr. Jones, was there anything we didn't touch on that you'd kind of like to mention here, or a topic that we didn't kind of brush?
No, I think we brushed pretty much the gist of concierge care and why people should at least try it.
Yeah. Oh, absolutely. Yeah.
Keoni, I interrupted you.
It'd be just like the Lay's potato chip there. By one time, they won't go back.
I love it.
Yeah. No, Dr. Jones, so how can people that listen to this podcast get in touch with you? Like, what's the best way?
My phone number is 904-569-7984, or my website, www.stjohnsdirectprimarycare.com.
Wow.
We'll put both in the show
thank you so
notes.
much. Yeah, we'll put them in there.
Speak about concierge medicine.
Thank you so much for being on.
What doctor says you can call me at this number to get in touch with me? You're usually going to have to call the office, talk to this person.
And what doctor actually uses the word cure? I mean, that's a rare thing. I mean, that's a real, and does it in a way that it has real meaning to it, you know, with certain things. So especially a lot of the lifestyle diseases. So
yes,
yeah,
a lot of lifestyle.
Dr. Jones, thank you so much for joining us.
Thank you for having me.